So now we have another sample question to go through. These are nice breaks in the studying so we can apply what we've learned and also to prime us for the next things that we're going to be encountering. So, the question, which of the following organisms is most likely the cause of the patient's condition? So we want to know the most likely cause. So we have to figure out what the patient's condition is and then figure out what the most likely cause is. Neisseria gonorrhea, Staph aureus, E. coli, Salmonella enterica, or Strep pyogenes. So we have a bunch of bacterial options here. We need to find out what's going on. So a 12-year-old boy presents to the emergency department with severe pain in his left knee and inability to walk. Okay, so the important thing is 12-year-old boy, severe pain in his left knee, and inability to walk. Okay? The child has a history of sickle cell disease, so that's a key feature. Sickle cell disease, and has been in and out of the hospital in the past for pain crises. Upon exam, his left knee joint is erythematous and significantly swollen. So he's significantly swollen and erythematous. These are all major indicators. He is febrile, but other vital signs are in normal limits. An aspiration is performed on the knee joint, revealing 60,000 white blood cells, 80% neutrophils, and low synovial fluid glucose. So this is a very large number of white blood cells, 60,000 in the synovial fluid with 80% neutrophils. So this definitely is a septic arthritis. All right, and also low synovial fluid glucose levels. All of these tell you this is probably septic arthritis. So we need to figure out what the most likely cause is in this 12-year-old boy with sickle cell disease. So don't get trapped here. There's a trick that I put in here for you, and we're going to talk about what that trick is. Neisseria gonorrhea. Is it likely that this 12-year-old boy is sexually active? Probably not. So Neisseria gonorrhea, even though it's a very common cause of septic arthritis in sexually active people, it's not likely in this 12-year-old. E. coli. Are we likely to have an E. coli septic arthritis? Is he having some kind of GI disruption or immunocompromise or diabetes? Probably not. So E. coli is probably not going to be the answer here. Now we're between B, D, and E. So what is the most common overall cause of septic arthritis in kids and adults? Right, Staphylococcus aureus. Okay, but what about in sickle cell disease? Is Salmonella the most common cause? No. Only in sickle cell disease, Salmonella is the most common cause of osteomyelitis. So in osteomyelitis, Salmonella is the most common cause in sickle cell disease patients. However, in septic arthritis, Salmonella is not the most common cause. It's only the most common cause in sickle cell osteomyelitis. So Staph aureus is much more common for septic arthritis than Salmonella. And Strep pyogenes is not a very common cause of septic arthritis. It's not as common as Staph aureus, and that is our answer. So don't get trapped. If we have a sickle cell patient with osteomyelitis, that most common cause is Salmonella. But if it's septic arthritis, the most common cause is Staph. Let's talk about some more Staphylococcus aureus diseases. So next one is pneumonia. So Staph aureus can cause a pretty severe pneumonia. So pathogenesis, you get aspiration of oral secretions. So how most pneumonias happen actually because of aspiration, including strep pneumonia and most of the different types of pneumonia. You have oral secretions that go past your epiglottis and into your larynx and into your lungs and start growing and form the pneumonia. So the problem is that Staph aureus pneumonia is very virulent and spreads and grows rapidly. So it forms abscesses from the coagulase, consolidates into the lung and makes dense infiltrates, and also empyema. What is empyema? That means you have an infection of the pleural space. So if you have an infection of the pleural space, you can get a exudative effusion and get pleural effusions there as well. Not only can it spread through aspiration of oral secretions, but Staph aureus can also spread hematogenously. So you have another site of Staph aureus infection, it can go to the lung and spread there through the blood. So it's associated with bacteremia or septic emboli from right-side endocarditis, and it's just as virulent as aspiration. So it can go from bacteremia from, say, a septic arthritis, from a endocarditis. It can go from anywhere in the body and spread to the lung, or it can be an embolus from right-side endocarditis. And when you have these septic emboli, they'll form nodules inside of the lung because they have the septic emboli lodging within the vessels, and it's just as virulent. So symptoms, remember, Staph aureus pneumonia is very, very severe. So it happens usually at post-influenza or post-URI. So a key feature is post-influenza, you can get Staph aureus pneumonia, and it's acute onset of fever, chills, chest pain, respiratory distress, and pulmonary infiltrates on chest x-ray. So the key feature is these can all present in any normal pneumonia, but Staph aureus is a very rapid onset and very severe. The patient will have respiratory distress really rapidly, and that's what differentiates it from other types. Most other pneumonias can have chills, chest pain, and infiltrates, but major respiratory distress is a key feature associated with Staph aureus. Same with abscess formation and loculated pleural effusions. A loculated pleural effusion means a very thick pleural effusion because of an empyema being found there. So what's the most common cause of post-influenza pneumonia? We said Staph aureus can cause it, but is there an even more common one? Yes, strep pneumonia is actually the most common cause of post-influenza pneumonia. So for diagnosis of the Staph aureus pneumonia, you need to culture the patient before you do treatment, because if you treat them first, you'll damage the culture and kill the bacteria in the culture, and you won't be able to definitively decide what the bacteria that caused the infection is. So the chest X-ray will show a nodular infiltrative appearance when you have Staph aureus, because it's spreading rapidly and can form nodules because of the abscesses. So it can also be associated with loculated pleural effusions if you have empyema associated. Remember, empyema is infection of the pleural space, and pleural effusions are within the pleural space. You do blood cultures as well. If it was spread hematogenously, you can do a blood culture and see what the cause was. Or you can do a respiratory tract specimen or culture to see what was aspirated and to grow the specimen and see if it was Staph aureus. So the treatment, remember, this is a very severe pneumonia, and if you're suspecting Staph aureus, you're suspecting MRSA, and you want to give IV vancomycin so you can cover the strongest types of Staph aureus, the MRSA Staph aureus. In addition to this vancomycin, you should also put in a chest tube to drain the exudated pleural effusions. That exudated pleural effusion is full of bacteria and full of pus and neutrophils, and you want to drain it out so it doesn't cause respiratory distress and worsening of the empyema. And if it's a very loculated, thick effusion that cannot be drained out, you can use actually TPA, which is a clot breakdown product, or a clot breakdown medication or treatment that can break down the coagulation around the abscesses, break down the effusion, and allow it to drain out. Now let's talk about septic arthritis. So what are we going to do for septic arthritis? So Staph aureus is the most common cause of septic arthritis, like we mentioned in the question before. So always remember that. Even in sickle cell disease, Staph aureus is the most common cause. Okay? What is the exception? There is no exception for Staph aureus. That's the trap. Alright? But in osteomyelitis, Salmonella is the most common cause. But in sickle cell, Staph aureus is the most common cause. Another important thing to know about septic arthritis is, in sexually active young people, the most common cause is actually not Staph aureus. The most common cause in sexually active young people is Neisseria gonorrhea, and that'll be the cause of septic arthritis in those patients. So commonly it's after bacteremia. Remember, bacteremia is a very common theme here. Staph aureus spreads through the blood, and you can also get it after a joint manipulation procedure, so the bacteria can get seeded into the joint space and cause the septic arthritis. So an example is you get a steroid injection or some kind of injection into the joint. Some Staph aureus can get seeded into the joint and start growing there. So some symptoms that we have here. We have a very painful erythematous joint, like we saw in the patient in the last slide, and decreased joint mobility because of all the fluid and the pus accumulating inside of that joint space. When you aspirate it, which is the next step you need to do for diagnosis, you get a very purulent drainage full of pus. So diagnosis, like we mentioned, always aspirate and get culture before antibiotics, because the antibiotics given first will actually mess up the culture and kill the bacteria, and you won't get as good of a culture to determine what the cause of the infection was. So gram stain and culture of the aspirated fluid to determine the source. Joint stain, joint fluid, white blood cell count will be greater than 50,000, and it'll be more than 75% neutrophils. So these are indications that you have septic arthritis. And also low synovial fluid glucose, because the bacteria and the white cells are using up this glucose. So low glucose levels. So treatment. Let's first talk about empiric therapy. So empiric therapy, we're talking about Staph aureus now, but say we do a gram stain and we see that it's a gram-positive organism like Staph aureus. Our empiric therapy is going to be vancomycin. And after we treat for vancomycin for a while and we get our culture results, we can narrow the spectrum of therapy. But what if it's a gram-negative on the gram stain? What if it's a gram-negative? We have to suspect Neisseria gonorrhea or Pseudomonas. Those are the big ones that we want to empirically cover for. So we'll give something like a third-generation cephalosporin, like ceftriaxone or ceftazidime, and also give like gentamicin or another aminoglycoside. We want to always give 2 antibiotics for Pseudomonas because it's so resistant. And the third-generation cephalosporin will cover the Neisseria gonorrhea. So say we already did empiric therapy, and now we found out that it was MSSA. We can give an IV oxacillin or cefazolin for 4 weeks. We've talked about before why we give these medications for MSSA, so we don't need to go over it again. For MRSA, vancomycin, remember, is our best treatment. We give that for 4 weeks for septic arthritis. So now some more septic arthritis diseases. Don't worry, we're almost done. So osteomyelitis. Staph aureus is the most common cause. It affects the highly vascular metaphysis of the bone. Metaphysis is where the epiphysis and diaphysis are, where they meet, and where the epiphysis becomes a diaphysis and vice versa. So that's very vascular, so Staph aureus will come and infect it. What's the exception? We mentioned Salmonella is the most common cause of osteomyelitis in sickle cell patients. So like always, it's secondary to bacteremia or local extension of an adjacent infection. So if you have a skin infection or a very major wound infection nearby a bone, the Staph aureus can go through the skin, through the tissue, and into the bone and cause an osteomyelitis. So what are some symptoms of this? You have localized pain over the affected bone and systemic symptoms. The major find is a localized pain. That's the key feature. You have pain over that bone with systemic symptoms. And if it's due to trauma or local extension, remember, it went from the surface all the way down to the bone, you get a draining sinus tract. You get purulent drainage from that sinus tract, from the inside tissues and bone, out to the surface. So diagnosis, like always, remember the common theme here, cultures before antibiotics. Always remember that. So the best initial test, remember the step 2 loves initial tests. The best initial test is x-ray of the affected bone. So that won't always show up as an actual symptom or a sign, but it takes a couple weeks for clinical findings. But you always want to do this first. Alright, here's what it'll look like if it's very severe. Look at how damaged the bone is. You have all these lytic lesions in the bone from the osteomyelitis. MRI, however, is the best test for imaging. So if you have an x-ray and you want the next step, if the x-ray doesn't show anything, you can do an MRI. And the best culture is a bone biopsy. Especially if it's an open wound, you can do a bone biopsy, and that can be very specific for what is actually infecting the bone. So now, what's the treatment? Alright, surgical debridement, especially if it's a wound, you want to clean up the wound and prevent it from getting worse so you can help prevent the source of the infection. So you always want to surgically debride it first, then give empiric therapy. So remember, empiric therapy for a wound, we don't know if it's gram-positive or gram-negative yet, so you want to cover everything. We'll first cover with IV piperacillin tazobactam for gram-negatives and MSSA, and it can also cover anaerobes, and we'll also add IV vancomycin if we're thinking of MRSA. So we'll give these medications together for osteomyelitis. And as we find out what the specific cause is, so we find out that Staph aureus is the cause, if it's MSSA, we'll treat it with MSSA-specific antibiotics, and if it's MRSA, we'll treat it with MRSA-specific antibiotics. And the antibiotics depend on what the culture results. Right, so empiric therapy is figuring out all the different causes and treating for them. Maintenance therapy is treating for the specific cause that we've found using the bone biopsy culture. Congratulations, we're done with Staphylococcus aureus. Now, we have some more staph to go through. So the new staph are coagulase-negative staph, Staphylococcus epidermidis. So let's talk about this. What are some characteristics of Staph epidermidis? First, it's a gram-positive cocci, like we talked about before, and it's novobiocin sensitive, which is not similar to Staph Saprophytic. That's how you differentiate through novobiocin. So epidermidis, it says epidermis on it. It grows on the skin. So it's commonly contaminant of blood cultures. So that's why you need to have multiple blood cultures for endocarditis, because it could get contaminated with Staph epidermidis. The major reason why Staph epidermidis is so problematic is because of its biofilm. And because of the severe biofilm, it can stick onto catheters and also the prosthetic devices. Prosthetic devices include hip joints or prosthetic valves. IV catheters include central lines, arterial lines, things like that. So you can see these right here. So the adherent biofilm allows for colonization. It can also colonize previously damaged heart valves. So while Staph aureus usually can colonize a native valve or a valve that's not been damaged previously, Staph epidermidis usually needs a previously damaged valve for it to be virulent. And rheumatic fever can cause damaged heart valves. Remember, for endocarditis, the most common cause of prosthetic valve endocarditis is Staph epidermidis. So if you have a prosthetic valve, that's what you should always be thinking about in the back of your head if a patient comes in with a new onset murmur and a low-grade fever and chills. So we have a subacute to chronic presentation. Remember we talked about how Staph aureus is a very acute presentation, happening within days to a week. However, with subacute to chronic presentation, it takes weeks to months for the symptoms to get worse, and it usually is pretty low grade as well when they're starting out. low-grade fever, night sweats, fatigue, and eventually, as this gets worse and worse and the bacterial colonies start growing in the heart, you can lead to separation of the prosthetic valve from the endocardium. That can be very severe, right? If you lose the prosthetic valve, now you have nothing separating the two parts of the heart from each other. So say it's like the mitral valve, and the prosthetic valve is separated. Now there's a hole between the left atrium and left ventricle, and more blood is going backwards into the left atrium than forward into the aorta, and you can lead to cardiogenic shock. So how do we diagnose this? Like always, multiple blood cultures and echocardiogram are the major ways to diagnose. Treatment? So for endocarditis, we don't know if it's Staph epidermidis yet. That's our suspicion as the most common cause, but there could also be gram-negative bacteria causing this also. Remember, it's a prosthetic valve. There are a lot of things that can form biofilms and infect it, including Pseudomonas. So the reason is that we're using vancomycin to cover for empiric epidermidis and gentamicin and cefepime to cover for Pseudomonas. Remember, we always use 2 antibiotics to protect against Pseudomonas. After culture results come back, we can target the therapy and give whatever specifically is needed. Say we find out it's Staph epidermidis, we can give a beta-lactam if it's sensitive or vancomycin if it's not. Remember, we talked about how it can also infect prosthetic joints and catheters. So what are some symptoms of this? The joint will fail because you'll have the infection damaging the joint and also infecting the joint as well, preventing the patient from moving that part of the body. So you have decreased mobility, which makes sense. The joint is damaged. Painful movement because you have swelling and edema and purulent accumulation inside the space. And you can even have a draining sinus tract if it infects up to the surface. So another thing is you get erythema and drainage of the catheter insertion site. So if you have a catheter in place and you see it's red and inflamed and draining, that means that there's some kind of infection there and it must be removed as soon as possible. You can also get fevers, chills, and hypotension if the bacteria get into the blood and cause systemic signs and findings. Now how to diagnose it. Remember, cultures first. So you want to get a culture of the blood and the catheter tip to figure out what's going on if it's a catheter infection, or a periprosthetic or joint fluid culture if it's a joint infection. So you always want to culture first and then give antibiotics. Initial test is going to be x-rays so you can see exactly what's going on inside the joint. And then the treatment is going to be empiric vancomycin. Remember, we're considering epidermidis to be the most common cause here. So you want to give empiric vancomycin because we are worried about the possibility of Staph epidermidis. And if we're also worried about the possibility of gram-negatives, we can give anti-pseudomonal drugs as well. You also want to remove the prosthetic joint and catheter, and you have to put a new one in. The joint's catheter is damaged and inflamed and infected. We don't want to keep it in there. That's the source of the infection, so it needs to be removed. Now Coagulix negative staph, part 2, Saprophyticus. This one's a lot simpler and doesn't have as many features, and it's not as dangerous as the other types of staph. So it should be a pretty quick one to go through. So Staph Saprophyticus, novobiocin resistant. This is how you differentiate it from Staph epidermidis. It's an asymptomatic flora of the female genital tract, so it's commonly found within female genitalia. And it's the second most common cause of UTI in young sexually active women. So commonly after a honeymoon, if a patient has a UTI or after having sex for the first time, you should consider Saprophyticus. But is it the most common cause? No. Remember, E. coli is the most common cause of UTIs in any population. But this one's a close second in sexually active young women. Next is diagnosis. We have urinalysis for diagnosis. And what are we looking for? Positive leukocyte esterase. That's a sign of white blood cells in the urinary system where they should not be. Also, if you have bacteria in the sample, that's an abnormality too, and a sign of Staph Saprophyticus being there. So take a look. You see all these white cells here and all this bacteria? These are not supposed to be in the urine, so you can tell that this patient has an infected urinary tract infection. So urine culture, however, is not necessary in young healthy women. You only do urine culture if there's a major risk factor. It's a complicated infection, such as having a catheter, immunocompromised, etc. But in young healthy women, UTIs are pretty common, and you don't need to do a culture. So how do you treat it then? The treatment is one of many oral antibiotics, okay? So Staph Saprophyticus will be treated with the same antibiotics that will cover E. coli. And these will be Bactrim, ciprofloxacin, and cephalexin. So always remember these bacteria as your first line, these antibiotics as your first line treatments for Staph Saprophyticus or E. coli UTIs.